All right, hey, it's Adam, and we're going to continue on with our talk about antibiotics. So we were talking about cephalosporins, which are in the same beta-lactam classification as the penicillins. You're going to see there's a little bit of difference between these two groups, but just know that they have a very similar mechanism of action by inhibiting that penicillin binding protein. And so something to note about generations and how they classify these generations will have an impact on what sort of antimicrobial spectra that it has. So in general, what you're going to see is that as you move up in the cephalosporin generation, you're going to find that you get more and more gram-negative activity is going to be increasing, and you can kind of see that here on this slide. You see increasing gram-negative activity. On the other hand, though, when you have the generation increase, you typically find that you're going to have decreasing gram-positive coverage, and there's going to be a caveat to that when we get up. Actually, there's a new 5th generation of cephalosporins that this picture does not take into account, but we'll find what the differences are there. And the nice thing about the 4th generation, you actually start to pick up really good gram-negative activity, but you also have better gram-positive coverage. You can kind of see how that kind of dips down in gram-positive coverage between the 1st, 2nd, and 3rd generation, and then for the 4th one, it starts to pick back up. And so we'll see that as we go through these different generations specifically. So the 1st generation of cephalosporins we have to deal with are going to be ones that are used a lot for more kind of like either pretty minor type of infections or for prophylaxis of some infections. So what we'll see, the main ones you find in this activity include things like cefazolin or Ancef. This one is going to be most commonly used if you guys ever go to work in the surgical world for surgical prophylaxis. I mentioned that on the skin you have a lot of gram-positive bugs, staph, strep, things like that. You're going to be living on the skin, and so in order to deal with that when you're cutting into someone's abdomen or something like that, you give antibiotics before and after, usually about a 24-hour period around the surgery, in order to help prevent those infections. So this is where this one commonly gets used. This is an IV product that we use very, very frequently. Has a little bit of staph aureus coverage, so MSSA coverage against that, and then sometimes you can also see used for UTIs. So it has a little bit of gram-negative activity, but not a ton. Keflex or cephalexin is going to be another big one you're going to use over the counter. And again, this is a very, very common over the counter, I'm sorry, not over the counter, but a non-prescription cephalosporin. They're going to see being used for lots of skin and soft tissue infections. And again, things like cellulitis. That makes sense based on the gram-positive coverage and also occasionally for some UTIs. You'll typically see that in more UTI failures with cephalexin, usually due to resistance, and because it doesn't have great gram-negative coverage, it's pretty easy for those gram-negative bugs to develop resistance against these 1st generation cephalosporins. One important thing to note about these activity, and this is going to be a class-wide effect here, is that cephalosporins do not cover Enterococcus. So even though they have really good gram-positive coverage here in the 1st generation, it does not cover Enterococcus, and that will be a class effect for the cephalosporins. Never covers Enterococcus. And again, you'll find some limited gram-negative coverage, things like E. coli, Proteus, Klebsiella. That's why you can get away with using it for some UTIs, but more often than not, I'll see a lot of people kind of bypass cephalexin and go to something else for UTIs. Next, we have our 2nd generation cephalosporins. We have things like cefotetan, cefoxitin. You can see these are both IV. We have things like cefuroxime or Ceprazil, which are good PO options. You're going to find these have more gram-negative activity than the 1st generation agents. So they start to pick up things like H. influenza, Enterobacter, although you will see some resistance develop to this, Neisseria, Proteus, Klebsiella. These are also pretty good for UTIs, probably even better than your 1st generation cephalosporins. And occasionally you might see it used for other things like upper respiratory tract infections or surgical prophylaxis. I would say that out of the entire group of cephalosporins, I see the 2nd generation used the least frequently out of the whole bunches, and we'll see why. The 1st generation is really good for things like surgical prophylaxis, whereas 3rd generation is going to be a lot more broad coverage for lots of different things. 3rd generation cephalosporins, ceftriaxone is going to be our main IV agent that we're going to use in this category. I'm sure a lot of you have heard of Rocephin before. This one is really nice because all of the cephalosporins are going to undergo renal elimination, which means they need to be renally adjusted. You have to change the dose based on a person's declining renal function. The one exception to this is going to be ceftriaxone or Rocephin. Because it primarily goes through the liver for metabolism, you don't have to worry about changing for renal function, which is great. Has really good strep coverage. I see this used for a lot of upper respiratory tract infections for patients who cannot tolerate oral medications, which is good. And then one thing to note about this is you cannot use this drug during the first 30 days of life. There is a contraindication where ceftriaxone will bind for this, or will try to compete for the same binding sites as bilirubin in infants and newborns more specifically. And so when you have displacement of that bilirubin, you can cause jaundice. And so that's why we don't use ceftriaxone for the first 30 days of life. We also avoid mixing it with calcium because this actually will cause a precipitation, which can either cause an embolus in the patient, or it could actually cause occlusion of the line, cause you to have to change out your line completely, which you like to avoid whenever possible. Next, you have ceftazidime or Fortaz. This one is used very, very infrequently, maybe because it has rapid development of resistance to it. It does have some good pseudomonal coverage for a little bit, but then it ends up becoming resistant. So this one I do not see used very commonly. Usually like some very specialized ID kind of cases. Cefotaxime though is used. This is going to be the preferred third generation cephalosporin for neonatal fever and sepsis. So if you have a neonate that comes in, they don't have a very good immune system, and they have a fever, one of the things you have to rule out is going to either be sepsis or meningitis. And so in this case, they will use a third generation cephalosporin because it has really good gram-negative coverage and has okay gram-positive coverage. And so we'll use this very frequently as an alternative to ceftriaxone because we already mentioned you can't use that during that first month of life. As far as PO options go, you have things like Ceftonir or Omnicef and then Cefixime. I probably see Omnicef used a lot more frequently than Cefixime, but again, another good one to prescribe outpatient. And these will have better gram-negative coverage than your second generation agents, loses more of that gram-positive coverage, but will have some good coverage against things like Serratia and Moraxella, which again will help it with some of the respiratory tract infections. Ceftriaxone is good because even though it is a time-dependent antibiotic, similar to the other cephalosporins, because it has a long half-life, you can actually get away with giving Rocephin every 24 hours most often. Sometimes for more severe infections, you may give up to, say, twice a day, but for the most part, it's once a day. So again, you see Rocephin once a day in that picture there, some of the original advertising for the drug. Moving on to our fourth generation cephalosporins, cefepime is going to be one of the drugs of choice here for neutropenic fever. Basically, if you have a patient who, say, is a cancer patient who has had their immune system wiped out by chemotherapy, or say like an end-stage AIDS patient, something like that, cefepime is a really good drug to use because it has good anti-pseudomonal coverage, it has a very good gram-negative coverage, and even though it's a fourth generation, we saw that in that graph you start to see the gram-positive coverage start to pick back up. So it has decent gram-positive coverage, does not cover MRSA or Enterococcus. So these are two big holes in the gram-positive coverage for this drug that you cannot use. You have to add on something else in order to cover for those. Also, this doesn't have anaerobic activity. So you can kind of think about this drug, cefepime, being similar to Zosyn, which we saw back in the penicillins, because they both have pseudomonal coverage, but the big difference is going to be their anaerobic activity. Zosyn will cover anaerobes, cefepime will not. And so we typically like to use cefepime because it has a little bit more narrow spectrum than Zosyn, and so sometimes you'll see a lot of people jump to Zosyn. It's kind of a go-to when you're really worried about things like Pseudomonas, but we like to use cefepime more often just because it has a smaller spectrum of coverage while still getting that Pseudomonas, and you see less resistance develop. You'll also see cefepime being used a lot for nosocomial infections, or those that patients acquire in the hospital. So for either hospital-acquired pneumonia or ventilator-acquired pneumonia, you'll see cefepime used pretty frequently there. Now the newer drugs, these have been approved in the last few years. We have two of them we're going to cover, one of which is ceftaroline or Teflaro. This one's really kind of interesting because it has good gram-negative coverage, has gram-positive coverage, similar though to other cephalosporins, no Enterococcus, but now has MRSA coverage. This will be one of the few cephalosporins you're going to find that actually has MRSA coverage, and also covers has anti-pseudomonal activity as well. So that's kind of a new, kind of interesting thing, how you can get kind of both of these drugs covered with just one drug, which is not something you see very commonly. This one you'll see used for community-acquired pneumonias, a lot of skin and soft tissue infections. These are the FDA-approved indications, but they do not need to be renal, or it must be renally adjusted. Really, ceftriaxone is the only way you can get away with not doing that. And then you also have ceftolozane and tazobactam. This one is a brand name called Zerbaxa. This one is, again, very similar to what we saw with piperacillin tazobactam. This is a beta-lactamase inhibitor that we use to help increase the coverage of these cephalosporins. You see good gram-negative coverage. We'll cover things like Pseudomonas, good gram-positive, but no MRSA or Enterococcus. So you kind of think about this more kind of like cefepime you would see. although it does start to pick up a little bit of anaerobic activity. So again, you see adding that beta-lactamase inhibitor just helps the drug to work on a wider variety of bugs here. So actually this coverage is probably a little bit more like Zosyn than Cefepime if I had to, categorize it. As far as indications go, you see it used for intra-abdominal infections. Now, it doesn't have such good anaerobic coverage that you can use it by itself, so that's why you have to have a drug called Metronidazole, which we're going to talk about a little bit later. And then we can also use this for some complicated urinary tract infections. So that's it for the cephalosporins. We're going to then move on and talk about our monobactams. There's only one drug in this category, and this is going to be called astrienam or azectam. Again, you can still see the beta-lactam ring right here. The only differences are going to be the ARD side chains that differ them from the other beta-lactam drugs. So this one's kind of interesting because it has only gram-negative coverage. It actually covers 0 gram-positive bugs or anaerobes, and actually it's going to resemble the spectrum of our aminoglycosides, which we'll talk about a little bit later. And so it does have activity against Pseudomonas, which is great. Has really good Enterobacteriaceae activity, but no gram-positives or no anaerobes. This one is not used very frequently. Its kind of claim to fame for a while was that it would have 0 cross-reactivity with patients who had a true penicillin allergy. Nowadays, we feel much safer about giving cephalosporins due to the literature and what that kind of reports, but this is where it was used as an alternative for people who had true penicillin allergies for a while. Again, nothing really special to look for as far as monitoring goes, but again, you do want to look at the renal function because you will have to adjust based on that. Next, we have our carbapenems. There's 4 in this group: imipenem, meropenem, ertapenem, and doripenem. I will say that the 3 we use probably most often, actually the one we use the most often, actually the only one I've really ever seen used clinically is going to be meropenem. Seen a little bit of imipenem, but we'll look at some of the coverage here and why we will use one of these versus the others in just a second. You'll notice here I have a picture of a nuclear bomb going off because these drugs are very, very potent antibiotics. These sometimes are lovingly referred to as gorillacillin because it will kill just about everything. Very broad spectrum coverage. It will have good gram-positive coverage, still no MRSA, so again, it's a notable hole there. Gram-negative coverage, so it does cover Pseudomonas, the exception of ertapenem, so that's one of the reasons why we don't use ertapenem very often. And has good coverage against anaerobes. They're very resistant to hydrolysis from a lot of beta-lactams, so because of that, they tend to stay susceptible to a lot of bugs, even though they may become resistant to a lot of other drugs. So we can use this as our drug of choice for multi-drug resistant gram-negative infections, right? We can use this for drugs that are producing extended spectrum beta-lactamase. Basically, this is a beta-lactamase that the bacteria can produce that is even more resistant to the beta-lactamase inhibitors we were already looking at. So if you see a bug that is producing ESBL, you know they're going to be very difficult to treat, and this is where our carbapenems can come in and help with this. You'll see this used a lot for nosocomial infections, and then also they have good penetration to the CNS, so you can use it for meningitis. Again, we like to save these drugs as much as we can, mainly because we once bugs become resistant to these, there's not a whole lot we have to treat at that point. We kind of run out of a lot of options, so we like to save these as best we can. And you'll see that in a lot of places you have to have special approval just to use them. So these do have to be renally adjusted, and this is actually really, really important, especially for this drug, imipenem or Prolongation, mainly because if you have levels of that build up, you can actually have seizures develop from that. So again, that's another reason why I don't use that one very frequently. Meropenem, though, is really our go-to. I've actually never seen doripenem used in the hospitals that I've been in, but meropenem is certainly the go-to drug. So that's it for the beta-lactam drugs. Those are all the ones that are going to be working on that penicillin binding protein. Next up, we're going to be working on the cell wall inhibitors from a different mechanism. So next we have vancomycin, which you can see is a very large kind of molecule here that is used very frequently for gram-positive infections. So the way that vancomycin works, again, is not a beta-lactam drug, does not inhibit that penicillin binding protein, does not have a beta-lactam structure. It is instead kind of classified as a glycopeptide. And essentially what it does is it's going to bind to the 2 D-alanines on the peptides that are used to make the cross-linking bits of the bacterial cell wall. And so by binding to that, you actually prevent them from coming together, and you help prevent the actual cross-link from forming. The cell wall breaks down, you have leakage of cell contents, the bacteria dies. You can kind of see here with the vancomycin sensitive bacteria where it's going to come in here, the blue things are vancomycin, they're going to come and bind into these dialamines on either end of the cross-link, and you will prevent this enzyme from coming in and actually causing the cross-linkage to occur. Now, this you find that a lot of bugs tend to remain sensitive to vancomycin for a period of time because it's more difficult to develop resistance than you see with a lot of your beta-lactam drugs. If you were to have something become resistant, a lot of times the bacteria will change the amino acid sequence of their these cross-links. So instead of having an alanine, they may put like a D-lactate on the ends here, and so the vancomycin doesn't know how to bind to that, and so you can still have that enzyme come along and cause that cross-link to form. You can kind of see that here. So again, you'll have you'll retain that integrity of the cell wall because you have that cross-link still forming there. So vancomycin only has gram-positive coverage. Really, the only thing we're going to be using it for is to kill gram-positives, especially MRSA. So this is the claim to fame that vancomycin has, is it has MRSA coverage. Sometimes you'll use it, especially for surgical prophylaxis in patients who have a penicillin allergy, but this is not done very commonly. And one other thing you may see vancomycin being a good drug for is going to be for Clostridium difficile. And we said that this is a anaerobic bacteria. And one of the interesting things is that vancomycin itself does not get absorbed from the GI tract very well, which is why we only give it IV. Except for the case of C. diff. C. diff is going to be within the GI tract and the colon especially, and you're going to find that we can give oral vancomycin, and that will actually kill off that Clostridium difficile. So it can be another drug. There's another one we're going to see that's the drug of choice for C. diff, but this is another option you can use. We use this for a lot of gram-positive based infections like endocarditis, osteomyelitis, and I mentioned again, rarely for surgical prophylaxis. If you have someone who has a true allergy, they can't receive cephalosporins or penicillins or anything like that. So again, I'm not going to ask you to memorize the dosing here. I just want to kind of have you guys start to see these things, start to think about the dosing, and so you kind of know what looks normal in some cases. But again, this is another time-dependent antibiotic, which means we're going to be dosing it pretty frequently. So you can see here every Q8 to 12 hours. Some cases you have to give it every 6 hours, especially in kids because they tend to have pretty good renal function. But this is primarily renally eliminated, which means that you need to make sure that you're monitoring renal function. And you'll find that this is actually one of the things we're going to do when we have therapeutic drug monitoring being performed. Vancomycin is going to be one of our main drugs we're going to do that for. And so one of the things you'll notice is we're shooting for a trough here when we do our therapeutic drug monitoring. So depending on the type of infection, we may shoot for, for more minor infections, maybe 10 to 15 micrograms per ml, or for more serious infections like maybe sepsis or osteomyelitis or meningitis, we may shoot for a higher trough. And the point there being, and I can get a pen to show you this, is that when you're looking at drug concentrations, again, this is going to be some very nice artwork here, but say the MIC for the bug was right here. What you want to do is when you're giving your vancomycin, you want to make sure that you have your peak and then you have your trough and your peak. And again, because it's a time-dependent antibiotic, you want to make sure that you keep the levels above that MIC. And so where you're measuring is going to be this spot here, this trough, before they get their next dose. By measuring that, you can make sure that the trough is above the MIC, and they're still going to be able to have that antibiotic killing effect rather than it dropping down below the MIC, and the bacteria can start to grow again, right? So again, that's why we measure troughs. We don't really worry about peaks so much because, again, if you're measuring troughs and you're getting within the right range, you're not accumulating so much. Your peaks are really high in that case. Sometimes we'll use loading doses. If you guys remember that term from pharmacodynamics, where basically we are giving loading doses, larger doses than normal, to try to get the steady state sooner. Instead of taking 4 to 5 half-lives to get the steady state, we just give one big dose up front, and it kind of starts the patient at steady state already. And now in some cases you will find bugs become more resistant, especially Staph aureus. So if you ever hear of VRSA, that stands for vancomycin resistant Staph aureus, that's where the MIC becomes greater than 2 milligrams per liter. It can be very difficult to achieve high enough troughs in order to kill this bacteria, and that's when you may have to discontinue and switch over to another tougher kind of gram-positive killer. So we'll talk about linezolid in just a few minutes here as an alternative to vancomycin. Again, just an idea of looking at the time to steady state. Again, it takes 4 to 5 half-lives or so, but we want to give loading doses in some cases, especially with those that are severely ill, to try to get to the steady state much sooner. Keep in mind that when you're doing therapeutic drug monitoring, you do not want to check the trough too early. We normally tell patients or tell providers before the 3rd or 4th dose is when you want to check your first trough, because that way you have an idea that you're actually at steady state and you'll know that this is actually a true level. If you check it too early and say, for instance, were to check the trough after the first dose, you're going to notice here it's going to be too low, and you may adjust your dose to either give it more frequently or say at a bigger dose, and that can lead when you get to a new steady state, you're going to be too high and you're more likely to see toxicity. Now again, you don't have to remember these dosing recommendations by any means, but just know that when you're looking at some of the protocols that you use in order to dose vancomycin, see here how the frequency you're going to be giving can change based on the renal function of the patient. So this absolutely has to be renally adjusted, otherwise you're going to see toxicity. That's not going to be good, because again, you causing the patient to become more sick in the hospital, insurance doesn't like to pay for that sort of thing. So this is why we do prospective drug monitoring to make sure our levels don't get too high. But as the renal function diminishes, you're going to get the drug less and less frequently, and allow for the kidneys to have more time to clear the drugs. You may go to every 24 hours. In some cases, you may just give a one-time dose and then say after dialysis, check another level to see if they're low enough. Or sometimes you'll just do kind of random levels, say every 24 to 36 hours to see where the level's at. Once it's down low enough, then you can redose them. So big monitoring you want to do, again, renal clearance. If you do not monitor this and the levels get too high, you can see ototoxicity. So it can have damage to the hair cells in the cochlea. So it can lead to different frequency hearing loss, which is no good. The other thing we can see is nephrotoxicity. So again, we're using this, and typically you're saving vancomycin for very sick patients. And so these are patients who are prone to having nephrotoxicity anyway, just either due to other medications they're on or due to renal hypoperfusion. But vancomycin can add insult to injury in this case and actually can worsen the nephrotoxicity. So you do want to watch for that. Other things you want to watch for. There is a situation or a reaction you can have called red man syndrome, and this is going to be an infusion-related reaction. This is basically a condition where the patient will have the drug infused in too quickly, and they will start to get very flushed. They'll get very red all over. The fever, chills, even phlebitis can happen here. Again, this is not a true allergy. This is not a reason to discontinue therapy. This is something where you just need to slow down how quickly you're giving the drug. So if they give the drug over an hour and they have red man syndrome, then you can slow it down and give it over 2 hours, or in some cases we have it to give it even longer than that. But again, just be aware this is an adverse reaction, not a true allergy. So again, you can see how often we're going to be given every 8 to 12 hours, usually for adult patients. Again, depends on renal function and will require that therapeutic drug monitoring. So in a lot of hospitals, you have pharmacy that will do this for you, but in some more rural places, you may be the one doing it yourself. So be aware of that. Be aware that you want to check the trough before the 3rd or 4th dose, not sooner than that, because you may lead you to increase your dose or your frequency too early, and you'll have high levels leading you back to this toxicity. Again, depending on the indication, you may find your gold trough between, say 10 to 15 micrograms per ml, 15 to 20. I'm not going to have you memorize this for the test, but just be aware that you'll have different gold troughs based on the type of indication you're dealing with. Typically, the more sick patients require higher levels because your bacteria might be either more resistant or maybe more difficult to penetrate that tissue. And so by having a higher blood level, you know that the level of the tissues will also be higher, just based on what you know about distribution of drugs. Again, in some cases, if you have patients with unstable renal function, you just do random levels where you give a one-time dose, and then you'll monitor their levels at routine intervals, and determine when you can dose the drug again. Here's some pictures of what red man syndrome might look like. Again, some people may jump to thinking this looks like an allergic reaction, but again, all related to how fast you're giving the drug. So moving on from our cell wall active drugs, we now have our protein synthesis inhibitors. So again, the nice thing about antibiotics is that they typically have more specificity for interacting with bacterial cells than they do with human cells. This is why it limits a lot of the toxicity that we see. And the main reason for that is because they have different targets. So our cell walls are made up differently from bacteria. Also, our ribosomes are different. And so this is where our protein synthesis inhibitors are going to be important, because they are going to be shooting for this 50S and 30S complex, which makes it the 70S ribosomal complex, whereas mammals have a 60S and a 40S. Because these are different enough, our antibiotics can target the bacterial ribosomes and not ours. So I'm not going to ask you the difference, which ones fall into 50S versus a 30S. This is really just for your information. But basically what's happening here is that by having the ribosomes being inhibited, you basically can prevent the elongation of a lot of these peptide chains. So it can interfere with tRNA coming in and reading mRNA coming from the nucleus and prevent new proteins from being made. One of the big things you're going to see as far as differences between our cell wall active drugs versus these protein synthesis inhibitors is that the cell wall inhibitors are typically bactericidal. Because again, if you don't have a cell wall and you end up spilling all your contents out, you're probably going to have cell death. Versus here, by inhibiting the proteins, the cell already has some proteins that have been made. It can still function for a time, but it will become more bacteriostatic, meaning that it will prevent the cell from replicating, but it will not kill it off outright. So again, this is where you're going to be relying on your own host immune system to come in and kind of finish off the job. And again, this will not be the case with all of these protein synthesis inhibitors. We'll talk about a few exceptions to that rule, but in general, they tend to be bacteriostatic. The first group we're going to talk about will be our macrolides. And so there again, you're going to bind to the 50S subunit and inhibit protein synthesis by blocking that transpeptidation step. So the tRNA can't add on new peptides or new amino acids onto the peptide chain that's growing, and so you prevent new proteins from being made. The three in this group you're going to see most commonly are going to be erythromycin, clarithromycin, otherwise known as Biaxin, and then azithromycin. I'm sure everyone's heard of Z-Pak or Zithromax before. These are typically going to be PO medications. Occasionally you may see them being given IV. For instance, you may see occasionally IV azithromycin or IV erythromycin, but this is pretty rare. And then erythromycin also comes in a topical formulation, which we'll see that come into play when we get to our derm section. So again, don't need to know the different salts and which forms are oral versus IV. Just be aware that these are different options when it comes to the macrolide group. Now, macrolides are this a group of antibiotics that gets classically overused, especially for a lot of upper respiratory tract infections or pneumonias that may be viral in nature. So we see a lot of resistance starting to develop to these antibiotics, but they still get used pretty frequently. They have good, pretty broad coverage for the most part. No anaerobic coverage, but you'll see they cover things like strep pneumo, MSSA, strep pyogenes, listeria. Again, no cover for Enterococcus, but they work for a lot of these either skin kind of flora or things you see in the upper respiratory tract, which is great. Also has good gram-negative coverage, again, for a lot of respiratory tract bugs like H. flu, Moraxella catarrhalis. Again, if I have a little indication here, you can see this would be azithromycin, would have better coverage than clarithromycin, which is better than erythromycin. Neisseria, Neisseria gonorrhea, Neisseria meningitis, things like that. Doesn't really cover a lot of other gram-negatives, so again, a lot of respiratory tract infections get covered with these macrolides. The other really big thing that we are interested in here is going to be these atypical pneumonias we're going to be covering here, or atypical bugs that we can cover here. So things like Legionella, Mycoplasma pneumoniae, Chlamydia, these all get covered by the macrolide. So this is really a good kind of coverage for a lot of respiratory stuff and a lot of other types of infections, as we'll see. So atypicals, decent gram-negative aerobes, and then gram-positive aerobes. So this is why, because they cover such a wide group of things, that they get overused, because you can give it to a lot of different types of patients and it probably will cure whatever's ailing them. Again, not clinically used for anaerobes, so we won't worry about coverage for that. So the things we'll see macrolides used most commonly for include things like community-acquired pneumonia, acute otitis media, pharyngitis, a lot of upper respiratory tract infections and some community-acquired pneumonias. You'll see them used for some skin structure infections. And then some other kind of specialized cases where we might see them being used include this one called Mycobacterium avium complex, or MAC. This is actually a opportunistic infection that occurs in more end-stage HIV patients or patients with AIDS. And so this is used both for prophylaxis and also for treatment. So you may see patients, once their CD4 count gets down to like 50, then you will start up giving something like azithromycin in order to prevent MAC from occurring, things like that. You can also use it for chlamydia. Sometimes you actually see erythromycin being used for conjunctivitis or pneumonia in infants due to chlamydia, because they tend to be more likely to have this if the mom had it during the birth canal. And then also for H. pylori. This is going to be an important GI bug we'll talk about as causing a lot of gastric ulcers. And so you'll see this used in combination with other antibiotics and other GI active drugs. We'll talk more about this later in the GI section of this class. So they work very well, but they also have a kind of a unique set of adverse reactions you can see. One of the big things you find with the macrolides is they cause certainly GI upset, which we see with almost any of the antibiotics, but you also can see more diarrhea associated with this, and this is primarily because they can actually help to stimulate motility. This is more seen with erythromycin because it actually can interact with the motilin receptor in the GI tract, and that will stimulate motility, cause diarrhea in a lot of cases. Sometimes we'll use this therapeutically, and so more often than not, I see a lot of kids who have kind of impaired gastric transit time, or if they have peristalsis, things like that, or I'm sorry, not peristalsis, but gastroparesis. We can use these drugs in order to help stimulate the GI tract. So that's a very nice thing you can see there. Cholestatic hepatitis is kind of a rare complication, and then transient hearing loss is also a rare one, which you normally see with kind of large IV doses. One of the big points to note here, and this will be very important, this is an important side effect to note with any of these antibiotics, is QT prolongation, right? QT prolongation can occur with many types of drugs, and so typically just being on one drug that causes QT prolongation does not sign you up for getting torsades, which is a kind of a unique arrhythmia you see with QT prolongation. However, once you start adding on multiple drugs that can do this, or if the patient has a congenital prolonged QT, this is where you're going to have more likely to see arrhythmias occur. This is where you need to check EKGs. So just be aware this is something you can't see. We'll find other antibiotics that can do this as well, but this is kind of the first one we'll note here. Another big thing to note with the macrolides is that they inhibit the CYP3A subclass of enzymes. So they are metabolized by CYP3A4. They will also inhibit that, namely erythromycin being kind of the worst for this, followed by clarithromycin and then azithromycin. So because they are inhibiting level CYP3A4 here, you're going to find levels of drugs that also get metabolized by CYP3A4 to increase. That means things like carbamazepine we use for seizures, cyclosporin we use as a anti-rejection drug, drugs like digoxin which we use for cardiac stuff. They can all be affected here. So it's really, really important that you look up your drug profile beforehand and look for any interactions, because CYP3A4 we know is super important for metabolizing half of the drugs that are out there. You need to check this before prescribing. Here's an example of drug-induced QT prolongation, kind of that mechanism for how that occurs. We haven't covered cardiac stuff here yet, but we'll certainly go over this in detail later on in the class. But essentially, one of the things we see is when you have repolarization of the ventricles, is that you have to have potassium efflux coming out. So again, here, if you're looking at your normal EKG, you'd see, again, atrial depolarization, ventricular depolarization, followed by ventricular repolarization. And so essentially what you're finding is this QT interval is that period that it takes for the ventricles to depolarize and eventually repolarize. So it can kind of get set up for a new contraction. When you have a drug coming and blocking potassium efflux, that tends to prolong that period where that period for the cell to repolarize, and so that leads you more likely to have interactions where you can have reentrant arrhythmias and things like torsades that can occur there. So again, very kind of scary arrhythmia, very important thing to note, because again, this is not something you want to cause in your patients when they otherwise had no cardiac history before. All right, the next class we're going to talk about will be our tetracyclines. Kind of the name makes sense here if you look at the chemical structure, four cyclic rings we have there. The three main drugs we have in this category include just the name tetracycline, we have doxycycline, and then minocycline. So these are also going to be protein synthesis inhibitors. They are going to basically, again, block this transpeptidation step where you're going to have tRNA bring in new amino acids into, to add on and elongate those proteins there. Again, very similar to what else we saw previously. These are also bacteriostatic, and they also tend to be broad spectrum, similar to our macrolides. So you see kind of green across the board here as far as coverage goes, and then as far as the dosage forms, you'll find that tetracycline and minocycline are available PO. Really the only IV option is going to be doxycycline, and probably the most common ones I see being prescribed are both doxy and then tetracycline. These have very good coverage against a wide number of different types of bacteria, namely including a lot of atypicals like Legionella, Mycoplasma, Chlamydia, as we saw previously. You'll also see it being used against a lot of animal-borne organisms, so things like Brucella, Borrelia, Rickettsia, Yersinia, which Yersinia pestis is actually what caused the bubonic plague. You'll also see it have good coverage against gram-positives, Enterococcus, MRSA, a lot of common gram-negatives, anaerobes. Kind of covers everything, even syphilis, covers Treponema palladium. or Pallidum, and also H. pylori. Does not really have good coverage against Pseudomonas and does not really cover C. diff. So those would be some notable holes in its coverage as far as that goes. So we use it for lots of different things because it does have wide coverage of different bacteria. So we can use it a lot for acne. So this is one of the most common acne medications we'll see as far as antibiotics go. Atypical pneumonias, so kind of used similarly to what we would see with our macrolides. And they also mention a lot of animal-borne diseases. So things like Lyme disease, Rocky Mountain spotted fever, also STDs like chlamydia. Docs would be a very good coverage for this. So the reason why we don't use it for everything is because there are going to be some pretty notable drug interactions and also some adverse effects. So one of which being there's a good food-drug interaction that happens here where it will actually chelate or bind with iron and also calcium. So you have to let your patients know to separate these medications out. If they're taking like a multivitamin or drinking milk or things like that, they need to separate them out because it will bind up the drug and prevent it from being absorbed. As far as adverse effects go, you will see photosensitivity here, so it's important to make sure they're using sunscreen, make sure they're not going to be more risk for getting sunburns, things like that. And then the other big thing here, a big contraindication, is that it can cause discoloration in teeth for people who do not have kind of fully developed calcium deposits on things like their bones and also on their teeth. So mainly what you're going to see is that doxycycline is going to be kind of the worst offender here. And so one of the things we'll see is we avoid this in patients that are less than 8 years of age. And you can also see some risk of depression of skeletal growth. So we actually will, this will be contraindicated for patients who are in their second or third trimester of pregnancy. So a big thing to remember about tetracyclines, not for kids less than 8 years old, and also not going to be for pregnant women, especially later on in their pregnancy, because you worry about this risk of skeletal growth stunting. And then also it has to be renally dose adjusted, so you do want to watch out for that. Next, we have our Tigecycline, or basically the Glycylcycline, kind of similar structure to the tetracycline, but a lot different coverage, as we'll see here in just a second. Tygacil also has very good broad coverage, as we see with most of the other tetracyclines there. We can use this though for a lot of kind of complicated either skin infections or intra-abdominal infections. That's kind of the main thing we'll be using it for. We will reserve, this is only IV, and we will reserve this for patients who have developed resistance to most of our other drugs. And so you can see it being used for things like E. coli, E. faecalis, MRSA, lots of different kinds of really nasty bugs there. We can also use it for these intra-abdominal infections. So lots of different types of gram-negatives or anaerobes that are going to be growing within the in the GI tract. I tend to like this drug a lot just because it's a nice kind of bright orange color it has to it. But again, as far as dosing goes, very similar to what we see with our other tetracyclines, usually every 12 hours or so. And again, nothing real special as far as adverse effects. Next up, another good group of gram-negative killers is going to be our aminoglycosides. In this group, we have amikacin, gentamicin, and then tobramycin. So big thing to note with coverage here is that these are going to be gram-negative killers only, including Pseudomonas, a lot of Enterobacter, E. coli, Klebsiella. So this is a really good gram-negative killer. Sometimes you'll see this used for Enterococcus, which we know is a gram-positive, but this will actually be used with other drugs for synergy. Basically, this means when you're using two antibiotics together to get greater kill than either one would do by itself, that's called synergy. And so we'll see this more when we get to our cardiac section and talk about endocarditis. Now these drugs are actually concentration-dependent killers, and so even though we used to dose these drugs every 8 hours, we actually now do it every 24 hours. We shoot for giving a really big dose, so get a high peak concentration, and then we'll have that post-antibiotic effect, which means that even though the levels are dropping down below the MIC for the bacteria, you still end up seeing kind of cell kill happening, and so we like it for that. We can give it less frequently. We don't have to worry about patients accumulating as much drug, which will be one of the big things we'll see with our adverse effects. We use this very frequently, and again, this is mainly going to be IV drugs on the inpatient side for things like febrile neutropenia, for sepsis, or for that intercoccal synergy I mentioned previously. As far as dosing goes, you want to make sure the levels don't get too high and accumulate, because we can see renal toxicity, so it can cause nephrotoxicity there, cause ototoxicity similar to our vancomycin, and so it has to be renally adjusted. So the two main types of drugs you're going to see being used with therapeutic drug monitoring from an infectious disease standpoint is going to be vancomycin and these aminoglycosides. So So again, looking at our dosing, we like to use once daily dosing nowadays because of the concentration-dependent killing effects. And when you're measuring levels, essentially what we're doing is measuring for troughs. And so if you were to look at our graph of kind of our concentrations again, so say we're looking at our concentration versus time, and say here is the MIC for the bacteria. Basically, what we're doing is shooting for a really high level, and then we're letting it kind of just drop down slowly. And even though it doesn't, the idea is to try to get the body clear all of it before giving the next big dose, and it'll kind of spike back up again. And so even during this time period, we are below the MIC for the bacteria, you're still getting antibiotic kill here, right? Or bacterial kill during this time period, even though you're below the MIC. And so by doing that, you prevent accumulation of drug. So hopefully by the time you check a level for the patient before their next dose, that level is almost zero at that point. And so it tells you the patient's not accumulating a lot. They're not going to have problems with having organ toxicity due to that. So usually we'll check a level around the third or fourth dose or so. There are some rare occasions where we may check peak levels, but it's more common just to do troughs these days. And so again, that's what you're going to monitor for. We do it before the third or fourth dose because again, we would be at steady state if the patient is accumulating drug at all. And the next type of drug we're going to talk about is called linezolid or Zyvox. Again, the drug classification itself is Oxazolinodinone. A little hard to say, so we're just going to go with Zyvox here. So again, this is another very good gram-positive killer. We use this as a backup to vancomycin when we're having resistance develop. So if we have things like MRSA or VRSA in these cases, which would be vancomycin-resistant Staph aureus or vancomycin-resistant Enterococcus, this is where linezolid is going to come into play. The nice thing about it, though, it does have IV and PO options, so potentially you could use it as an outpatient, but it's very expensive, and because we like to save it for resistant bugs, we try not to use it as much as we can. But again, no gram-negative or anaerobic coverage, and the only things we're really going to use it for is things like hospital-acquired pneumonias with MRSA, or if we had resistant community-acquired MRSA pneumonias. Some toxicity you can see with it is both thrombocytopenia is a rare thing we can see, and then also kind of one of the things that a lot of providers don't really think about is the fact that it works very similar to some of our drugs called SSRIs. And so we'll talk about this in the behavioral section, but SSRI stands for selective serotonin reuptake inhibitor. Basically, if you have depression, you're most likely going to be on a drug that falls in this category. Basically, it's increasing levels of serotonin within the synapses. Zyvox itself actually can inhibit an enzyme called monoamine oxidase, which will also increase serotonin levels. So the idea is if you had multiple drugs that are acting through this pathway to increase serotonin levels, you can have what we call serotonin syndrome. We're going to talk about this much more in detail when we get to the behavioral section, but just know this is a common drug interaction that people don't usually take into account, and so you can see this drug interaction coming up very frequently where if you don't think about it, if you don't really think like, well, why is the patient acting weird, why do they have hypertension or hyperthermia, and they don't think and go back and think, hey, maybe it's serotonin syndrome. That's one of the big things we miss a lot in the hospital. So again, oftentimes you'll see it's used for vancomycin-resistant Enterococcus. These drugs only have gram-positive coverage here, and I'm actually including another one called daptomycin. I'll talk about that mechanism in a second. But again, linezolid still falls into the protein synthesis inhibitor category. And as far as monitoring goes, you want to watch for platelets. And then also, as far as dietary stuff goes, tyramine is a drug product or a product you'll find in certain foods like beers and aged cheeses and meats, red wine. This is a precursor to serotonin, so it can actually lead your risk for having that serotonin toxicity to increase. So we do want to watch for those tyramine-containing foods. Again, we'll talk more about that in the behavioral section. This other drug called daptomycin or cubicin is kind of interesting because it doesn't really work on the protein synthesis, but what it does is causes bacterial depolarization and will actually inhibit DNA, RNA, and protein synthesis. And so because it wipes out a lot of these functions, it ends up becoming bactericidal. This is one we use for, again, very resistant gram-positive infections like VRE. And so we will use it as kind of a backup to vancomycin typically. Some of the monitoring you want to watch for this is it can cause muscle breakdown, so you want to watch for muscle pain, also creatine phosphokinase levels, which is another product that spills out of the muscles when they break down. And another thing that's interesting is it cannot be used in pneumonia, mainly because the surfactant in the lung will actually destroy the drug and lead it to be not useful. Next up, we have our fluoroquinolones, and so this is another common class of drugs that most people are probably familiar with. They've probably heard of Levaquin or Cipro before. Here's a few examples which we'll talk about, but you have things like levofloxacin, ciprofloxacin, and moxifloxacin. These are kind of the most common ones you'll probably see out there in the clinical world. So their mechanism, they are going to be working to inhibit these enzymes called topoisomerase. There's a few varieties like topoisomerase 2 and topoisomerase 4. Essentially what we're seeing is that topoisomerase are a group of enzymes that help to cause single strand breaks in DNA that will allow for relaxation and retightening of the double helical structure in DNA. You have to have this unwinding occur in order to get to a point where you can have like enzymes come along like DNA polymerase and things like that. So if you inhibit this, you actually increase the number of strand breakages that occur, and so you end up having cleavage of the DNA. Once the cell kind of has enough damage done to the DNA, that's when you'll trigger apoptosis, and that will cause cell death to occur. So again, these would be considered bactericidal. Now, key points about the fluoroquinolones is they are going to be the drug of choice for a lot of community-acquired pneumonias, and again, a lot of people get this overprescribed to them because it does have pretty broad coverage. We don't like to use Cipro as far as a respiratory fluoroquinolones, we'll say, mainly because of some of the coverage issues, which we'll talk about a little bit later. But certainly, otitis, sinusitis, you can use it for that. Hospital-acquired pneumonias, we may use this for higher doses due to resistant bugs, and then occasionally use it for UTI. You don't want to use moxifloxacin for this because primarily, even though the fluoroquinolones are primarily going to be renally eliminated, and they have to watch for renal elimination and change the dose, moxi is actually only going to be metabolized to the liver. So the drug levels never really get that high in the kidneys or in the bladder. You're not going to be able to use this for a UTI. The drug never gets there in high enough levels to kill those bacteria. Sometimes use it for certain infectious diarrheas, occasionally some skin stuff, usually not Cipro though, osteomyelitis occasionally. And so again, it will cover a lot of different bacteria. We'll see that spectrum will change a little bit based on generation, which we'll look at in just a few seconds here. Now, as far as drug interactions go, again, this will chelate very similar to the tetracyclines to things like iron, antacids, multivitamins, calcium, dairy products, so watch for that. This will also increase your QT interval as well. So if you were to mix a macrolide plus a fluoroquinolone, you could see that how both of those could also increase the QT interval, make you more likely to have an arrhythmia. Some elderly patients will have CNS disturbances here. So again, it's one of those things where you can't tell if the infection is getting worse or maybe it's the drugs you're actually giving them. So watch out for that. It also can have a tendency to increase your effects of warfarin, which is an anticoagulant, so it can lead to more bleeding and bruising, which we'll look at why that is in just a second. Now, we overuse these drugs very frequently because it is so easy just to give someone a prescription for Levaquin, even though they may be dealing with a viral infection and things like that. But we're seeing a lot of resistance to these drugs, which is a shame because they are really good drugs for the most part. So because of that, you can end up seeing things like a lot of collateral damage, especially with normal skin flora, gastric flora, and that can lead to things like C. diff developing. So that would be a risk with using these medications. So just be aware of some of those. So we'll start with kind of second generation fluoroquinolones. We don't really use first generations much anymore, but Cipro being kind of a very good example of this. Has good gram-negative and atypical coverage, but again, it doesn't really have good, reliable Pseudomonas coverage, so that's again why we kind of avoid it for a lot of respiratory stuff. You can see here, these are, even though they're dosed every 12 hours or so, or maybe even fewer, less frequent in some cases, these tend to be concentration-dependent killers. And again, renal elimination is important here, so you do need to adjust your dose for that. Now, Levaquin is going to be considered a third-generation fluoroquinolone. You'll notice this is the left-handed form of ofloxacin, so levofloxacin is just the left-handed version of that. It's just one of the enantiomers there. It has improved gram-positive coverage over the second generation, so over Cipro, and better pseudomonal coverage. So this is why we use this very frequently for community-acquired pneumonia, a lot of strep pneumo and atypical coverage. You'll get a lot of coverage for that. So this is why this is really good for those kind of respiratory tract infections. Again, you see this one probably most often given just daily. So again, another kind of key indicator, this is probably a concentration dependent killer, but again, must be renally adjusted. You have moxifloxacin, which is also a third generation. Again, better gram-positive coverage here, good pseudomonal coverage, and again, very similar usages that we'll see for Moxie. Again, you cannot use this for renal or urinary tract infections because, again, it's metabolized primarily in the liver. The concentrations don't get high enough to kill off stuff in the urinary tract. You'll also see a lot of moxifloxacin being used for ophthalmic or otic purposes, so just be aware you'll see it used in different routes. We'll cover that in the ENT sections later on. So again, mentioned the dietary interactions with cations like iron or calcium. You can see some photosensitivity with these. And then note that this will inhibit CYP1A2. Again, not as clinically important as 3A4, but another thing you want to look for those interactions to make sure you're avoiding any problems prior to prescribing. Do need to watch for renal elimination with everything except for moxifloxacin. Look for QT prolongation here. Again, increased risk for torsades. And then one interesting kind of unique side effect here is tendinitis and tendon rupture that can occur. Sometimes it's thought to happen more in children, so you may be more cautious with giving a fluoroquinolone in a child, but I'll tell you we use it very frequently in MORs, but if we can use something else, we certainly will over a fluoroquinolone. Next up, we have Clindamycin or Cleocin. This is a interesting coverage because it is a very good gram-positive cover, or has good gram-positive coverage, and it also covers anaerobes. But it has no gram-negative coverage. So again, it will cover things like MRSA, cover all these anaerobes, and so that's why it's very good for either skin and soft tissue infections, or it's going to be really good for intra-abdominal infections. So again, you can use it for osteomyelitis, cellulitis, sometimes for surgical prophylaxis in penallergic patients. And again, use it for gut stuff as well because it covers those anaerobes. Now, you can't use it by itself in the gut because, again, it has no gram-negative coverage, but again, it will have very good anaerobic coverage. One interesting thing you can also see is that clindamycin has the ability to bind up exotoxins, which is something you will see more commonly in certain gram-positive infections like toxic shock syndrome. Kind of the classic presentation is the female patient who left a tampon in for too long, and they end up getting either staph or strep infection that will end up releasing these exotoxins. It makes the patient become very, very ill, very sick, and go into a kind of a shock-like picture. Clindamycin will be used occasionally just to end up binding up a lot of the exotoxins to try to help the patient start to recover a little bit faster. Some of the side effects you can see here is some blood dyscrasias that can happen here, including neutropenia, thrombocytopenia. This is pretty rare, but one of the big things to worry about is going to be Clostridium difficile. This is one of the biggest causative agents for causing C. diff infections, and with a further complication being what we call pseudomembranous colitis. It's kind of a further kind of worsening of the colon kind of picture. There's a lot of inflammation going on. You can see a lot of bad issues come about from this. This is what we're trying to prevent. This is why sometimes you'll see probiotics being prescribed along with clindamycin to try to help restore the normal gut flora. Next up, we have sulfamethoxazole and trimethoprim. This is commonly found in a combination in a drug called Septra or Bactrim. This is going to be either given IV or oral. Really try to use oral whenever possible here, and I'm sure a lot of people have heard of these drugs before, especially for like UTIs and things like that. So this is interesting because it kind of helps to block the activity of folic acid within the bacteria. Basically, you find that these are working on two different steps here in the pathway. Essentially, what you find is sulfamethoxazole, which is commonly abbreviated as SMX, is going to inhibit conversion of para-aminobenzoic acid, or PABA, to dihydrofolic acid. And so, again, you're blocking this step right here via this dihydroteric acid synthetase. Again, not important as enzyme here. Just know this working on PABA to prevent utilization of folic acid. Trimethoprim, otherwise abbreviated TMP, inhibits the further conversion of dihydrofolic acid to tetrahydrofolic acid, or THF. So you can see here trimethoprim be working on the secondary step. By blocking both of these steps, the bacterial cell cannot use folic acid, which is really important for generating things like new base pairs for DNA and things like that. So eventually to bacterial DNA damage, which again can further lead to bacterial cell death through apoptosis. As far as coverage goes, you're going to have decent coverage for MRSA, strep pneumo, listeria, so good gram-positive coverage. It does not cover Enterococcus. And then it will have some decent gram-negative aerobes as well. So Moraxella, Neisseria. Also, you have a few kind of oddball bacteria that only show up in certain disease states. So things like Burkholdia cepacia and Stenotrophomonas multifilia. These are two bacteria you actually see come up in cystic fibrosis patients, more kind of late-stage patients. And again, you can see some other gram-negatives you can occasionally use Bactrim for. Also, you'll see this used in patients who have an impaired immune system to help prevent certain secondary or opportunistic infections like toxoplasmosis or nocardia or pneumocystis carinii. So sometimes you'll see it used in cancer patients or AIDS patients in order to help prevent these from developing. So again, PCP or that pneumocystis carinii pneumonia, again, you see this in a lot of AIDS patients or patients who have neutropenia. Uses quite a bit for UTIs or bacterial prostatitis, things like that. Respiratory tract infections occasionally use it for that. And then a lot of times you'll see it for enteritis due to Shigella or like Travel's diarrhea due to E. coli. And as far as adverse reactions go, you can see some rash and hypersensitivity. This is one of those drugs that you worry about, Stevens-Johnson's syndrome and toxic epidermal necrolysis. So again, warn your patients if you see blisters or any kind of skin sloughing off, things like that, they need to be evaluated at the ER kind of immediately. Because it affects folic acid use, even though it's more specific for the bacteria than it is for us, you can see things like megaloblastic anemia, agranulocytosis can happen from that, so be wary of that, and then occasionally some hepatic issues here. Biggest thing to worry about as far as drug interactions go, though, is that you can see increased levels of phenytoin, rifampin, and digoxin. A lot of this comes about by inhibiting this enzyme CYP2C9. So that's one thing you want to worry about, and especially you can see issues with warfarin therapy, because you can see your INR go up pretty significantly due to that CYP2C9 inhibition. Basically, warfarin has higher levels, so it's going to cause less clotting factors to be made. That should more likely to see your INR go up. Also, you're going to find that we have a drug that works very similar to trimethoprim, sulfamethoxazole, but it works on human cells, and it's called methotrexate. So that's a drug we see used for rheumatoid arthritis. You see it used in cancer, and so you can actually end up seeing decreased clearance of that drug, which can lead to pancytopenia, which is something you see very commonly when you have too much of these chemotherapeutic drugs on board. Next up, we have a drug called Flagyl or Metronidazole. This is a drug that is primarily going to be used for parasites and then also for anaerobic infections. Basically, this is working by interacting with bacterial DNA, loses that kind of helical structure and causes more strand breakage. So you can kind of think about it a little bit like the fluoroquinolones, but does not have, not working on the same enzymes necessarily. So the places we'll use metronidazole are going to be for Clostridium difficile. This is actually our drug of choice for C. diff. We can either use this IV or PO. If you remember back when we were talking about vancomycin, that one is actually only going to be used PO for C. diff, and that would be kind of a second line agent behind metronidazole. Sometimes we'll see this used in addition to certain gram-negative killing drugs as an intra-abdominal combination. So I most frequently see this when we're doing surgical prophylaxis for patients coming in for appendicitis. We'll give this along with ceftriaxone, which is a third generation cephalosporin, which will get a lot of gram negatives. This will get the anaerobes, and you're less likely to find post-surgical infections happen there. And then also some sexually transmitted infections, we may use Flagyl as well. So as far as interactions go or side effects, there's something we call the disulfiram-like reaction that is important to be aware of. This is where basically if a person drinks ethanol along with metronidazole, you're going to have an enzyme called acetaldehyde dehydrogenase being affected. And so another drug that does this is called disulfiram. The brand name was Antabuse, and it was meant to prevent patients who are alcoholic from drinking alcohol, because essentially what happens is you start to break down the alcohol, but you can't break down a byproduct of it called acetaldehyde. So that levels will build up, cause a lot of headache, nausea, vomiting, flushing. The patient feels really, really bad, and so this is why we tell patients, don't drink with metronidazole, because you can see a similar reaction. You can't get rid of that byproduct, and so you just feel really, really terrible. Next we have Polymixin B and Polymixin E. These are going to be some antibacterials that we don't use very frequently on the inside of the body. We use a lot of these primarily on the outside, and we'll talk about them more in the topical section, in the dermatology section. Essentially what they do, though, is they actually kind of pierce themselves through the outer membrane, especially if you have a lot of gram-negative rods and things like that. And it will displace things like magnesium and calcium and disrupt the entire cell membrane. They're very, very good at killing gram-negative bacteria, but you're going to find that they're very, very toxic to human cells as well. And so we don't have a lot of resistance against these drugs, so they haven't really been used in the last 50 years because we have such safer medications nowadays. And so we will use these occasionally for patients who have become resistant to really every other type of gram-negative killing drug that are out there on the market. So I don't see these used very often, but just for your just for edification, just know that they're going to be used occasionally for these multi-drug resistant bacteria. And the big things we want to worry about is causing nephrotoxicity, so they can damage kidneys, they can damage the CNS and cause neurotoxicity, and then they can also actually lead to worsened neuromuscular blockade. This is basically when you give a patient in the ICU a paralytic to help them breathe while on a ventilator. This can actually worsen that and make a patient be paralyzed for longer than you want. So that covers the antibiotics for this section. We're going to, again, talk about these over and over again as we get to different organ systems as we cover them. And so again, this is just the fundamentals. I just want to get you the basics down now and get the kind of the understanding of how these drugs are working, common side effects, drug interactions, things like that. So that way when we talk about them again, you can hit the ground running and already know a lot about these drugs. Okay. So next we're going to move on and talk about dermatology. Continuing on, we're going to start talking about dermatology and how it relates back to pharmacology. So some general information. Skin is one of the largest organs of the body, or the largest organ of the body, and it is primarily used to help to protect underlying structures from trauma, temperature, penetrations, moisture, all kinds of things. And so it's important to consider when we're applying drugs directly to the skin, we have to keep in mind the thickness and the permeability of the skin. And so that changes based on which parts of the body you're talking about. Places like the face, scrotum, armpit, they tend to absorb medication very well because the skin is either more permeable or is thinner. Places like the palm, soles of the feet tend to be less permeable. Also, you have to consider the concentration gradient, where the increased concentration means you're going to have more drug transfer occurring. And so this is important when you're talking about things like corticosteroid resistance being overcome by just increasing the concentration and thus increasing the amount of drug being absorbed. And also the skin can actually act like a reservoir and it kind of extend the half-life of some medications, leading to just daily dosing of some short-acting meds when the skin kind of builds up a nice depot of drug. And then we'll see that the vehicle itself, a lot of these products can actually have therapeutic benefit, either by moistening, drying, or occluding the site where it's applied. So again, when we're considering what type of dermatologic vehicles we're using, which just means what is the drug being placed in, we have to consider the drug solubility, so how well it gets dissolved in the vehicle. If it does not dissolve, it's not going to get absorbed through the skin very well. The ability for the vehicle to hydrate the stratum corneum, again, very dry, scaly skin does not have good absorption, but by moisturizing that and hydrating that stratum corneum, you do have increased penetration. And also how stable the drug is in the vehicle. We find that when a lot of these drugs are in kind of a water-based product, you tend to see more bacterial growth. You can see breakdown of the drug over time, and so it's important to consider how stable the drug will be in that product. So the general rule of thumb when you're selecting different vehicles is that if it's wet, you want to dry it, and if it's dry, you want to wet it. So for instance, if you're having a lot of acute inflammation, you're having oozing, crusting, or vesiculation, you want to use more drying type agents versus if it's having scaling like invication. This is where you can use things that are going to be more hydrating, so like creams, ointments, things like that. So we'll talk about the different vehicles in just a second here, but also considering things like hairy areas, they require things like tinctures or lotions. They can be pretty convenient to use because they can help to get down to the skin a little bit more easily. And then we'll see that you want to avoid ointments and creams. It kind of makes a bigger mess when you're dealing with kind of hairy areas like that. So other types of delivery systems we can have, including things like wet dressings. These help with evaporative cooling. You can cause some vasoconstriction. They're very good for like ulcers, oozing lesions, things like that. So for instance, you can use things like normal saline or acetic acid, which is basically just diluted vinegar and water. You find things like powders tend to be more drying and cooling, and they can help to absorb moisture, and that can make more surface area for evaporation. So that's one thing you use powders for. And so basically when we're coming down to different, the more common delivery systems, we find things like lotions, which tend to be a suspension or a solution of a powder in a water vehicle. These tend to be drying and pretty cooling for the most part. Solution, just being a substance that's been dissolved in some other substance, so a solute going into your solvent. And again, these drugs have to be soluble and they're solvent, otherwise the penetration, any kind of absorption is not going to be very good. We also have gels, which are going to be clear, non-greasy, non-staining, and non-occlusive, which means they don't stick around quite as long, but they typically are very quick drying, and oftentimes they'll contain different types of alcohols. So, for instance, propylene glycol. These are good for hair-covered areas, or say like the face, where the patient wants to avoid kind of a greasy look after application. A lot of things like ointments tend to be much more greasy, maybe because they have a higher oil content to them, and these mostly contain either alcohol or water. Emulsions, you're going to find there's two main types of emulsions we'll deal with. There's either oil and water, which means you have a little bit of oil and a lot of water, or water and oil, a little bit of water and a lot of oil. Basically, oil and water emulsions, and this helps with drug solubility and things like that. They typically are going to provide better occlusion than lotions, but are going to have less effect than you would see with an ointment. It's kind of like the middle ground here, and they're going to be more useful in dry skin conditions. Water and oil tend to be more easily applied, and they're going to be more useful where there's kind of like dry skin is going to be predominating here. And then creams is going to be the most common vehicle. Most of these end up being water, oil and water emulsions. Again, some of them can be water and oil for sure. But basically, the idea here is you kind of rub them in until they vanish, and they're not very occlusive. So kind of once they are kind of rubbed off or they've been washed off, they don't really stick around that well. And so these are going to be better for kind of non-irritable dermatoses or like non-acute kind of things. Ointments, again, many of these end up being water and oil emulsions for the most part, so a higher oil content here. These are good for relieving dryness, brittleness, and protecting things like fissures that can form, and these are very occlusive for the most part, so they tend to have a lot of greasier feel, they stick around a lot better, and they're not good for really hair covered type areas, but they're very good for damaged skin to help provide that kind of occlusion. There's also aerosols. These are going to be application is very easy. It does not require a lot of contact. You can kind of just spray it over the area. But these tend to be less efficient and more expensive than others, and typically have a lot of alcohol bases, and so they tend to be a little bit more drying. So kind of looking at different forms from going from kind of most drying to most to least drying or more hydrating. You can find things like tinctures that tend to be more alcohol based, wet dressings, lotions, gels, all the way down to getting into creams, foams, and ointments tend to be the least drying. So you can kind of see, based on the type of skin you're dealing with, whether it be wet or dry, the type of agent you want to be using here. Here's a nice table. I feel that kind of gives you a good breakdown of the different types of solutions that we can have here, whether it be creams, ointments, gels, and kind of tells you some of the pluses and minuses. We'll talk more about these in detail, but again, a good thing to kind of go back and kind of reflect on when you're trying to keep in mind the differences between these dosage forms. So first thing we'll talk about are going to be some of our topical corticosteroid agents. Typically, you're going to find a lot of these being used for either inflammatory, pruritic eruptions, usually a lot of allergic contact dermatitis, eczema, different things like that. So you're going to use topical corticosteroids for a lot of inflammatory conditions. You're going to find that a lot of them have different preparations that are available. You can usually find that most of your patients will be able to use low and medium strength agents, but you're going to find for more severe inflammation, you're going to be able to use more stronger agents. And we'll talk about those a little bit later and what categories they fall into. Keep in mind that topical corticosteroids can make some of the following things kind of worse because they do have anti-inflammatory properties to them. So things like acne, warts, fungal infections, the immune system is not able to really attack these if they're being inhibited by things like corticosteroids. That'd be one thing to just keep note of. And finally, adverse reaction side effects. These tend to be a little bit more infrequent, but they are going to be more likely to occur with higher doses, with more potent agents, depending where you're applying them to. So especially if you're applying them to thinner areas, we're going to be more likely to have absorption. You want to kind of avoid using stronger agents there. So you can see things like dermal atrophy, fine hair growth, bruising, striae that can form when you're using these products. Again, not super common, but something to keep in mind when you're kind of dealing with more potent agents. So again, you'll find that a lot of these different products come in multiple strengths and dosage forms, and so it can be kind of confusing in deciding like, which one should I use for my patient. Just looking at hydrocortisone, which is kind of one of the more wimpy, kind of least potent corticosteroids you could use, you can see that it comes in a 1% ointment, 1% cream, 1% lotion, 1% gel, and there's different concentrations out there, different salts. And so again, when you're trying to choose which one should I prescribe, a lot of it comes down to, well, what type of skin am I dealing with? Is it wet and oozing? Is it dry, having lichenification, things like that. This can help you decide what type of dosage form you're going to use. And then usually the degree of inflammation is going to help you decide what kind of strength you're going to need to use. So again, typically as far as application goes, applying at least twice a day and up to 4 times a day to receive kind of max benefit. And as long as it's still there on the skin, you're still getting some benefit. But a lot of times the patients end up trying to wash these away because they don't like the feeling of it. That can limit how effective these can be. Now, again, you can treat the same indication with multiple strengths. Typically, you're going to see that for flare-ups, you're going to use higher strength or higher potency agents, but for more kind of routine care, kind of maintenance care, using more mild preparations are going to be better for those patients. Keep in mind that absorption rates are going to vary with the surface area, so how much skin you're applying the drugs to and the skin characteristics. So for instance, looking at the face, the cheeks are about 13%. You always want to use low potency products here because again, you can have a lot of absorption, you can have systemic effects that come from this versus with the forearm, maybe only say 1%. Using medium or high potency agents, you can get away with that because you're not going to have nearly as much absorption as you would with, like, say, the cheeks. Ointments tend to be more potent than the creams, mainly because they're more occlusive and they stick around for longer and they typically are better absorbed. So again, ointments, again, better for dry skin. Creams are going to be a little bit more drying, better for some oily skin. Again, you want to be careful when using topical steroids to thin skin like the face, scrotum, skin folds, things like that. You really only want to use low potency steroids because you can actually see systemic absorption and systemic side effects, which we'll talk more about in detail a little bit later on. So we're not going to cover every single topical corticosteroid out there, but probably just the more potent ones, the ones you're going to run into more commonly in clinical practice. Again, if you go and work in dermatology, you'll probably be able to come back and school me quite a bit on this. So I don't deal with dermatology all the time. So this is why we try to hit the common things you're more likely to see. But starting with the low potency, hydrocortisone acetate 1% is probably one of the most go-to ones you're going to run into, whether it be the ointment, the cream, or the lotion. You can find OTC versions of this over the counter. So it's a good first-line agent, very common, very inexpensive. Note here that the salt form does make a difference. So for instance, if you get the hydrocortisone valerate 0.2%, even though it's a smaller percentage here, it's actually more potent and is actually considered a medium potency agent than the hydrocortisone acetate. Okay. So things like desinide, 0.05%, ointment and cream can be used, again, low potency agents can be used on body folds, as interadjacent areas, on the face, things like that. Now, as far as medium potency goes, triamcinolone acetonide is going to be one of your go-tos here. This is either Aristocort or Kenalog. It's a very popular one. You see it used more for like psoriasis, eczema, more kind of those a little bit stronger inflammation here going on than in some of the cases you may use just low potency hydrocortisone for. High potency agents, things like fluocinolone, ointment, cream, solution. Here, the Lidex is one brand name for this. These are going to be better for lesions that typically are resistant to more medium potency steroids. They'll be absorbed better. They'll be a lot stronger acting at those individual sites. And then you have ultra high potency, again, really using these high and ultra high potency just for kind of flare-ups or very severe inflammation. Clobetasol is a very good ultra high potency steroid here. Here, you really have to look at the risk benefit ratio, and really should not be using these agents unless you're really kind of in the field itself. So if you're working with these agents all the time in the dermatology office, that's probably one thing. But if you're dealing with these at like the urgent care, you probably want to stay away from these kind of higher potency agents. Hydrocortisone can probably get you most of the way in 9/10 of the cases out there. We also have some topical immunomodulators. These are also good because they can be anti-inflammatories, but they work a little bit more specifically because instead of affecting all aspects of inflammation as the corticosteroids do at the site of the nucleus, these are working more specifically on things like T cells, mast cells, and whatnot. And so these can be alternatives. These typically are more expensive and really should only be used as alternatives if patients do not tolerate the corticosteroids very well. You can see that it may have a better side effect profile here. Things like the thin skinning, the atrophy, discoloration, things like that. You also don't get any adrenal suppression from these agents. There's a small risk for cancer that is seen with these, and so that is one concern that some people may shy away from these, not use these as first line. But you have things like Macrolides and then Tacrolimus. Tacrolimus is also something you'll see used systemically for organ rejection prevention because it is an immunosuppressant. It will prevent things like a rejection of foreign material in the body. So if you had like a liver transplant or something like that. Tacrolimus usually is about comparable to a medium potency steroid. Macrolimus is probably more like a low potency steroid there. You're going to find that, again, they can be pretty well tolerated. May see some skin burning and warmth. And again, there are some risk of lymphomas. It hasn't been proven necessarily with the topical agents, but there's some concern with that. So again, if the patient tends to be at high risk already due to family history, that would be one thing to consider there. Okay, these tend to be causing photosensitivity, so avoid sun exposure or use high SPF sunscreen, or educate your patients to do that, and then be careful if they have a weakened immune system, because this could further and this should be really applied to the corticosteroids as well, since that can also be immunosuppressive there, right? So again, these are considered first line steroid sparing agents, right? So if you didn't want to use a steroid, use these as an alternative if they cannot tolerate or cannot use topical steroids for some other reason. So one place where you might be using a lot of these corticosteroids is with contact dermatitis. This is probably one of the more common things you're going to be treating as far as these skin manifestations. It can either be acute or chronic, and usually it's due to direct skin contact with either chemicals or some sort of allergen in the environment. A lot of times you're going to see this due to pretty simple things to diagnose, like soaps or detergents. So it's why you always ask, hey, is there any new soaps or things like that you're using? Minority of cases may be due to specific allergens, so things like poison ivy or poison oak. So again, typically you're going to find with just localized involvement, so kind of small amount of body area surface we're talking about here, things like topical hydrocortisone or some other topical steroid can be used kind of as a first line. This helps to relieve a lot of the itching and the inflammation. If there is a weeping lesion, because that is pretty wet already, ointments may not be the best option there. Gels may be a little bit better suitable option. They tend to be more alcohol based and tend to dry a little bit better. Occasionally you may find patients with such bad dermatitis that they have to use oral products, things like oral steroids, which we'll talk about in a different section of this class, but that is going to be the minority of patients and probably need to be farmed out to like a specialist for that. And then you might use systemic corticosteroid therapy more in cases where either, like I mentioned, that the inflammation is very severe, or if you have very widespread conditions to where applying hydrocortisone over the entire body, if the whole body's involved, may be kind of impractical, and that's where kind of systemic or oral options may be better for that patient. So just some pictures of dermatitis you may see out there. All right, some of the things you may use occasionally, things like astringents. These typically are going to be agents that dry mucus secretions. They shrink skin cells and typically cause blanching or whitening of the skin. Things like this include calamine lotion, a lot of topical products that are zinc oxide based. And both astringents tend to cover and protect epithelial surfaces, and actually can help aiding and reducing inflammation. So it's a useful adjunctive agent for helping to reduce inflammation. Occasionally, if you're having a lot of itching with these dermatitis patients, oral antihistamines can be used. We'll talk more about those later on in the class, but things like Benadryl or diphenhydramine or Unisom or doxylamine can be used to help with that. We typically don't use a lot of topical antihistamines, even though things like Benadryl have a roll-on topical product, mainly because of some questions about the efficacy of those. Another pretty common skin condition you may be treating is impetigo, and this is typically caused by staphylococci in most cases, or potentially streptococci, depending on kind of the environment or depending on other patient conditions. Typically what you find is that we end up using more systemic agents in order to treat this versus topical products, especially if it's more involved disease or more widespread. So in these cases, what we can use is basically because we are covering staph, penicillins are a good agent to start off with. And so if we can use the anti-staphylococcal penicillin like dicloxacillin, this tends to be pretty useful. And then cephalexin, which we know to be a first generation cephalosporin, does have some MSSA coverage. These are very good agents to use for impetigo. Again, we want to use narrow spectrum antibiotics wherever possible in order to avoid overusing our bigger guns, essentially. So Also, clindamycin might be another good agent to use here if you're considering MRSA, and a lot of this is dependent on how they responded to previous drugs, if you tried that, or if they've had drug failures, or depending on the where you're working, you may find more MRSA out there in the community, which clindamycin is very good at covering that MRSA. Things like dicloxin and cephalexin will not cover MRSA, just MSSA. Potentially, you could use topical antibiotics. We have one called mupirocin or Bactriban. This one works against bacterial tRNA protein synthesis. And so this is very good for covering MRSA, and sometimes you'll see that used in hospital patients who they get a nasal swab for MRSA. If they're positive, they'll cover that in order to prevent spread of infection in the hospital. We also have rotapamulin or Altabax. This is also inhibiting ribosomal protein synthesis in the bacteria. Again, by using topical products, they kind of limit systemic absorption. You see less side effects as well and less drug-drug interactions. Of course, with any topical agent like this, you can see potential irritation, dermatitis. So just be aware of that. It may not be quite as effective as a systemic antibiotic, but you kind of limit those systemic effects as well. So just again, keep in mind that when you're treating impetigo, you want to make sure it's not contact dermatitis to begin with. And again, because the etiologies are different, the treatments are completely different. And here you wouldn't want to use topical corticosteroids because you want the body's immune system to be reacting against the bacteria. We're just trying to help it along with giving antibiotics. Corticosteroids only end up being immunosuppressant, and so that's not very useful for helping to fight infections. Okay, up next we're going to talk about acne. This is another very common outpatient thing we're going to be treating in your career. Basically, we know this is due to multiple factors. It's important to understand these factors because this is what we're going to use to decide what type of drugs we want to use for. So a couple things you see here is one, increased sebum production. Again, this is a fatty lubricant that gets secreted by sebaceous glands in the skin. So too much of this ends up clogging a lot of those pores and produces a nice anaerobic environment for bacteria to grow. You also see this abnormal keratinization within the pilosebaceous canal. These also work to plug up the sebaceous follicle. And then after this period, you kind of have the nice growing environments for bacterial colonization. So one of the big ones you see here is this Propionibacterium acnes. And these are going to be a gram-positive organism, anaerobes, that can colonize that follicle. After this, once you have the colonization here, you have your own body reacting to it, and this is where you see a lot of the inflammation coming from. Now, there is some evidence to point kind of to and away from some of these things, but things like psychological stress, diet, cleanliness, sexual activity, they probably don't directly contribute to the severity or the exacerbations of acne. We do know that increasing androgens tend to activate acne, so especially if patients were taking exogenous androgens like testosterone, or especially like during during puberty, things like that. We know that imbalances in both sides of the sex hormones, both estrogens and androgens, tend to possibly contribute to acne. Just here are some pictures of normal acne you might see in your patients. And so there's a lot of environmental factors that can help to exacerbate this. So things like heat and humidity can help to induce comedone formation, pressure or friction. So think about like football players in high school with their helmets and shoulder pads. And again, these are probably not cleaned super well. So again, bacteria can be growing in those nice sweaty, hot environments. You also find that excessive scrubbing or washing can help to increase the inflammation and make acne worse. And sometimes things like hairstyles, they're low in the neck or the forehead can worsen this. And then depending on the season, sometimes ends up being worse in winter than in summer. We do know that physiologically, patients who are in an increased stress state tend to have an increased glucocorticoid secretion. And because these are anti-inflammatory, we do see some risk for having more bacterial colonization occurring there, which can worsen acne in some cases. So it could be one thing you can potentially see there as well. So again, that pooling of the sebum creates an anaerobic condition. This allows for that proliferation of the bacteria. That T cell response we have from our own host inflammatory system causes a lot of the inflammation. And then when we have that lipase from the bacteria, it will actually start to hydrolyze things like triglycerides into free fatty acids. And so this is where we see that keratinization and the microcomedone formation there. When we have the immune system attacking the site, this is where we have a lot of cytokine production and chemokines, and this is what generates the pus. We find a lot of those pimples. There's two main varieties of acne you'll run into: the non-inflammatory, which you have a lot of open and closed comedones, and then the inflammatory variety, which is more papupustular, nodular lesions you're going to find there. And this will, based on what type of inflammation category they kind of fall into, will dictate what type of drugs we're going to use for these patients. Again, just a picture showing kind of the formation of acne as we go along. So have a normal hair follicle, you have our overactive sebaceous gland, which is going to allow for kind of a buildup of epithelial cells and keratin. This whole thing gets clogged up and eventually will cause kind of closing up of the gland, or the follicle, I should say. And this is where you're going to have proliferation of bacteria, and then the immune system is going to come in and start attacking, and this is where you have a lot of the pus generation forming there. And this is where the peak of inflammation is occurring. So as far as acne goes, there's no known cure, but treatment can certainly reduce the severity. And so therapy is usually considered more of an art than a science. It's going to be very much individualized to the patient. And some patients respond really well to certain types of therapy. Some patients respond terribly to the same thing. And so you have to really individualize it for them. Basically, what we're going to see is that treatment must be preventative wherever possible, because once lesions are already there, there's not a whole lot you can do for those. And so whenever we're initiating treatment, it's going to take some time. And so we need to allow for at least 1 to 2 months to see how the patient is kind of progressing, see what that delta is from starting treatment to that new time period before modifying any treatment there. So even though the patient says, hey, it's been a week, this stuff's not working, you need to let it last a little bit longer before you can say that you need to change something. Our goals of therapy, because it is a chronic disease, we want to start with early aggressive treatment and then kind of fall back to more maintenance therapy. So you want to start kind of using stronger drugs, using higher concentration and stuff, and then once you get the acne under control, then you scale it back down to using kind of the lowest strength you can, using the fewest number of drugs during this maintenance therapy period. We want to help to reduce the number and severity of lesions, slow any progressions of signs and symptoms, and limit the duration and recurrence of those symptoms, and hopefully we can avoid any kind of long-term disfigurement seen with scarring, and then also any kind of psychological suffering, especially in high school. A lot of these kids, how they can be with pizza face and other kind of similar remarks. I don't know if you guys ever had to deal with that, but certainly can provide some psychological trauma for your patients. So it's also important to note when sometimes it is the providers who are causing the acne in our patients, and this is where we can see drug-induced acne occur here. One of the most common ones you're going to run into are going to be systemic corticosteroids, so things like dexamethasone, prednisone. You can see a lot of pustular inflammation of the trunk. You see this several weeks after the initiation of therapy, and not typically the kind of low potency agents like hydrocortisone, but what you can see is that higher potency drugs, higher doses lead to more of this acne that occurs there. And then the other thing is, because these corticosteroids tend to be anti-inflammatory, once you remove these drugs away from the patient, you actually see an initial worsening because they have all these comedones that are forming, all these P. acnes bacteria that are there. Once you take that away and the patient's immune system kind of ramps back up and starts to interact with all those comedones, that's where you see a lot of increased inflammation initially, and it's going to kind of back down. Other common ones that can cause acne include things like antiepileptics, which we use for treating seizures, tuberculostatics, which we use to treat tuberculosis, and then lithium, which is a common one used for bipolar disorder. So the critical target for treatment is obviously going to be the microcomedone. By eliminating that follicular occlusion, you kind of arrest the following cascade. As long as you leave it in kind of a nice aerobic environment that does not get clogged, you won't have proliferations of bacteria, you won't have the inflammation afterwards. And so we're going to use a combination of both pharmacologic and non-pharmacologic therapy here, and use multiple mechanisms to try to target these different pathogenic steps. Typically what you find is that early on with mild to moderate therapy, you're going to use more topical drugs, and then with more moderate to severe disease or more diffuse disease, the larger the body area you're covering, the more likely are to use systemic therapy. So the ways that we can affect these different pathologic steps, you'll kind of see here, and we'll talk about these more in detail when we get to the individual drugs. But affecting that, normalizing the follicular keratinization, this is where things like topical retinoids, azelaic acid, and benzoyl peroxide will be effective for this. Decreasing sebum production, again, the retinoids, isotretinoin, which is a systemic retinoid, and then hormone manipulation will be important here. We'll look at suppressing bacteria, which is where a lot of our antibiotics and benzoyl peroxide are going to come into play, and then preventing inflammatory response. Antibiotics and retinoids, again, will be useful here. So we'll go over these in more detail, but you can kind of fall back on this slide to say, okay, well, what different steps do these different drugs work on specifically? So as far as cleansing goes, it's important to remember that obviously a clean face tends to be less likely to have acne than one is that is very oily and dirty. But it's important not to be too cleanly, right? We find that a lot of the surfactant systems that we use, a lot of the soaps and detergents tend to disperse and remove the fats and oils from the skin, which is a good thing. But too much of this can lead to more drying and irritation, and that can lead more inflammation to occur and more likely to have acne develop. Also keep in mind that with these soaps, once it's rinsed off, there's no further active product that's remaining there, no further antibacterial activity, and so you'll see that the soap's only effective while it's there, essentially. Not very occlusive, I should say. Also, the higher pH of these soaps may degrade activity of some other agents, especially certain ones we'll talk about a little bit later on. If it inactivates them, then obviously it's not going to work very well. So that's why the time frame needs to be important as far as when you're applying certain things. And it also may make it less tolerable on the skin. So really, a lot of people recommend don't wash too frequently, maybe twice a day is usually pretty sufficient for most patients. With topical therapy, it's important to know that it only works where it's applied. So again, it requires application to the entire affected area, which is pretty easy if it's just the face, but if it's the entire trunk, that can be more difficult. And also note that most of these topical therapies cause skin irritation themselves. This can either lead the patient to discontinue it early, and that's why we want to start with lower strength products and then gradually increase to see what they can tolerate. Also, you may want to consider using non-alcoholic products, mainly because they tend to be more drying and can worsen the irritation and the the pruritus and just the burning that they're going to be feeling. Here's a nice slide that kind of sums up that table we saw before, where you're looking at different pathogenic steps, and you can see where the different drugs are going to fall into play. Well, again, we'll talk about these more in detail when we get to the individual drugs in just a second. Now, benzoyl peroxide is probably one of the first things that a lot of people jump to for treating acne. It's available over the counter and available pretty much everywhere. It's pretty cheap. And so most patients will probably already have tried this by the time they come to see you for further treatment. Basically what benzoyl peroxide does is it helps to penetrate the stratum corneum. It gets converted over to benzoic acid, and that has actual activity against the P. acnes, and will also have some peeling and comedоlytic effects, which means it'll start to break down the comedones and break down that abnormal keratinization. Typically you want to start low and go slow. So maybe 2.5% solution once daily, and then you increase strength and frequency as tolerated by the patient. Sometimes you'll find this in combination with certain antibiotics that we use topically, so we'll talk about those in just a few minutes. But the big things to know as far as adverse reactions go is that it can bleach the hair, can bleach clothes, and certainly will cause skin irritation, just like we talked about a second ago. So again, let them know, hey, if you're wearing this at nighttime, watch your sheets, watch your clothes you're wearing, because it can cause bleaching there, hair. So it's an important education point for your patients. Next up we have azelaic acid, and so this is basically just a straight chain dicarboxylic acid, and so we don't know the full mechanism, but it's probably kind of a little bit similar to benzoic acid, and then it has some antimicrobial activity. One of the other interesting kind of unique things about it, though, is it actually helps to inhibit the conversion of testosterone over to dihydrotestosterone. This is oftentimes abbreviated DHT, and so we know that androgens like testosterone and DHT tend to have a pro-acne sort of effect, and so DHT is actually the more potent form of testosterone. So if you can block conversion of testosterone to DHT, you can limit some of those androgen effects and hopefully limit the acne. So that's one other reason why we think this might be useful. Again, start once daily and increase to twice daily is tolerated. And here you're going to notice that skin irritation is the biggest adverse effect and typically gets better over the course of several weeks. Next up, we have our topical retinoids. Main one here, or kind of the primary one, being retinoic acid, otherwise known as tretinoin. This is actually the acidic form of vitamin A. And again, we don't know why completely that this works, but we do know that it has several activities against these different pathologic steps, including helping to correct the abnormal follicular keratinization, helps to reduce those P. acnes counts, and also it helps to reduce the inflammation by the host immune system. This is kind of first-line therapy for non-inflammatory or comedonal acne, and oftentimes gets combined with other agents for more inflammatory kind of cases. You may also see it's being used for more kind of like anti-aging or beauty purposes, useful for things like wrinkles or dyspigmentation. As far as adverse effects go, they tend to be irritating on the skin. So things like erythema, desquamation, burning, or stinging, these tend to get better with time. And by using emollients like ointments and creams and things like that to hydrate the skin tends to help with this. You'll also find that the retinoids tend to be cause photosensitivity and can cause severe sunburn. So patients really need to wear high SPF sunblock if they're going to go out in the sun. We also avoid the retinoids during pregnancy. We'll talk more about this in detail when we get to isotretinoin, but this is going to be kind of a class effect with all of these retinoids. Okay. Now, tretinoin, as we mentioned, being kind of the first drug in this category, is photolabile, meaning that it's out in the sun, it will break down, and so you need to apply it nightly. And also, benzoyl peroxide can inactivate it. So it may be one of those things where you use benzoyl peroxide in the morning, use tretinoin at nighttime. You have to separate them out, otherwise, like I said, the tretinoin tends to get inactivated. We have other topical retinoids. So we have things like adapalene. This one is stable in sunlight, stable benzoyl peroxide, and also tends to be less irritating. So this might be a better go-to drug rather than just the regular retinoin, depending on cost and things like that. You have tazarotene. This is sometimes used for acne and also psoriasis in some cases due to its anti-inflammatory effects. Sometimes combined with things like topical steroids help reduce that irritation. We have a couple other ones like alitretinoin and bexarotene. These actually get used in certain types of cancers, and so certainly would not be used for acne, but they fall into the same category as being a retinoid. We can also use topical antibiotics for acne, including things like clindamycin, which we know has good gram-positive activity, erythromycin, sulfacetamide, which falls into the same category as sulfamethoxazole. If you go back to I talked about those drugs in the previous section, and then also metronidazole is used occasionally as well. When topical treatment is not going to be enough here, we will use systemic retinoids. This is kind of the next step here. When you have very diffuse disease or very inflammatory disease, isotretinoin can be used here. This is really the big systemic retinoid. Accutane is the brand name here, and typically effective within 1 to 3 months or so. Now this one's interesting because it is absolutely contraindicated in pregnancy and breastfeeding because it's very teratogenic, meaning it can cause very severe damage and death to potential death to a fetus. And so this is one of those things where you have to sign up for a specific program called iPledge. Not only does the provider have to sign up, the pharmacy has to sign up, and also the patient. Female patients have to produce negative pregnancy tests regularly. They also caution men to avoid use as well, or make sure they're at least using some form of physical contraception in order to make sure they're avoiding any kind of transmittance there, because again, that can, even the men sharing bodily fluids to the female could potentially impact a growing fetus. That's how serious this is with these teratogenic effects. So again, you have to have a special program for your patients because it is so teratogenic and contraindicated in pregnancy. Now, as far as adverse reactions go, again, you are going to find this is going to be like the topical retinoids, but more systemic. And so it's going to cause this retinoid dermatitis where you see a lot of erythema, pruritus, scaling, photophobia, so you're going to be kind of sensitive to bright lights. You can also see things like alopecia, brittle nails, arthralgias, negative effects on their serum lipids. And also you want to monitor for signs of developing depression. For whatever reason, messing with vitamin A in the body tends to have an effect on patients' mood, and so you can either see worsening or new onset depression with these patients. So again, this is why we like to hold this one off until they've kind of failed other therapies because of all these side effects here. It can be very, very effective, but the side effects are pretty significant as well. And then we also have systemic antibiotics, which are going to be used for more extensive or difficult to treat disease. The more common ones we're going to use includes tetracyclines, and then also trimethoprim, sulfamethoxazole. Again, these tend to be safe, effective, and pretty inexpensive for the most part. So again, oftentimes used in combination with topical products to get kind of more synergy there. Some other drugs you may use occasionally for the treatment of acne include things like salicylic acid, which is chemically very similar to acetylsalicylic acid, which is otherwise known as aspirin. It's been used for many years, but we don't have enough studies to really support its use routinely. We do know it's a keratinolytic, which can be useful for breaking down some of those comedones and things like that, and probably has some mild anti-inflammatory, antimicrobial activity. So it's not used routinely, but can be used occasionally. You see this used a lot more commonly for warts and things like that to help break down that skin there. Occasionally you can use anti-androgens to block some of those androgen effects. Things like spironolactone, which is actually a diuretic, but has anti-androgen effects, may be used occasionally there, or sometimes as a gel. And then sometimes we can recommend oral contraceptives to female patients. These tend to be useful in some of them where the abnormal hormone levels are causing the acne in the first place. This can help kind of balance things out and make their hormone levels very consistent throughout the month. So things like ethinyl estradiol, norethindrone, ethinyl estradiol combination products can be used occasionally. Some patients it can worsen their acne, but some people will clear it up very well. So it just depends on your patient and see how they tolerate it. Some of them might be on the oral contraception for other purposes anyway, and so this might be just a happy side effect, as if their acne gets better anyway. Occasionally for more severe kind of individual inflammatory nodules, we use intralesional steroids. You don't really see a ton of systemic effects, but higher doses and more lesions that you're treating can lead to more systemic effects, and occasionally local tissue atrophy can be seen there. And then really only very rarely do we use oral corticosteroids, things like prednisone, dexamethasone. Do we use those for patients who have a kind of adrenal hyperactivity? Sometimes using very low doses of that can actually help to have a negative feedback loop effect on the adrenal glands and help to tamp that down a little bit. And so you can also see this for a very short course kind of pulse therapy for patients who have really highly inflammatory disease. So this slide's a little busy, but the main thing to point out here is the stepwise approach that we're going to use for therapy. So if I have a patient who is failing one type of therapy, what do they move to next, or what should I start with? And this is based on their symptomatology and kind of what they've done previously and how it's worked for them. So for instance, if they have kind of more minor acne, this kind of type 1, you can start off with like a topical retinoid as your drug of choice. They can also consider benzoyl peroxide. They probably already tried that and failed it at home, which is why they're coming to you. Potentially salicylic acid. And the question is, if they fail this, what do you move to next? And so this is where you start to use combination therapies, where you can consider looking at, say, topical retinoids plus benzoyl peroxide, or like a topical antibiotic can be used there. If that's not working, then you start to look at more systemic antibiotics like doxycycline. Again, remember who that would be contraindicated for. So if it was a kid less than 8, which hopefully doesn't have too much acne, or if it was a pregnant patient, you would avoid things like doxycycline. But here you use systemic antibiotic plus a topical retinoid or benzoyl peroxide, right? So again, combination therapy is a big thing here. And then if that's not working still, move on up to systemic antibiotics plus a topical retinoid. And then if that's still not really working, this is where you start to consider things like oral isotretinoin. So for instance, you can see it's back here, oral isotretinoin, except for those women who may or may not become pregnant, again, you have that iPledge system that kind of helps with that. Anyway, so again, it's a stepwise approach. Always try to avoid oral isotretinoin unless they've failed kind of everything else. But basically start topical, move oral, start with the oral antibiotics, and that's still not working. That's where you can start to consider using the oral isotretinoin. Again, because the side effects are so severe, because of the potential teratogenesis, if they become pregnant, that's just something I like to avoid if we can. Another type of acne you may see is acne rosacea. Again, you can see this kind of typical reddening of the skin. You can see here is a picture, I believe, Winston Churchill, who was someone who suffered from acne rosacea. And again, you're going to find that the patient is going to complain of burning or stinging, flushing of the affected areas. And it's really different from acne vulgaris, because you're going to find the patients typically going to range in the ages, usually 30 to 50, and they don't have these comedones, really just this reddening of the skin. Typically women are going to be more affected, and you can find certain things will trigger it, like hot liquids, alcohol, spicy foods, etc. How can we treat this? We can use some maintenance drug therapy. Is going to be useful for kind of helping to prevent flare-ups from this occurring for the kind of chronic term. We use a product called topical bromonidine, or Mirvaso. This is actually a drug we're going to see again when we get to talking about glaucoma in the ophthalmic section. But basically it's a vasoconstrictive alpha-2 receptor agonist. Essentially it helps to vasoconstrict, so it helps to prevent a lot of that blood flow, that increase in blood flow that occurs when they have a trigger that causes the reddening of the skin. Those cutaneous vessels tend to stay more constricted, less blood flow is going there. You've also seen occasionally people have tried using topical antibiotics like metronidazole, sometimes use things like clindamycin, some systemic therapies, but really we will use mainly the topical bromonidine or potentially this azelaic acid. Finacea is also now approved as well. It can be potentially useful. Another thing you may run into commonly in the outpatient world is going to be pediculosis or lice infections. Certainly we have things like body lice or scabies. These are going to be occurring usually people like with poor hygiene or overcrowded conditions. You have pubic lice, which is generally going to be spread by sexual transmission, and then you also have head lice. And so you can find this as an epidemic in all children, regardless of their living conditions. Them being in school tends to be a pretty easy vector for them to spread from one to another. As far as for treatment for head and body lice, we find that our permethrins are going to be acting as our main drug of choice here. Basically, permethrins are very specific for working on the lice themselves and are less, not really selective for affecting humans, fortunately, and they act as paralytics. Basically, they're opening or they're preventing these neuronal sodium channels from occurring, and so if you prevent that, you prevent nervous signal transmission, and thus the bugs get paralyzed and they die essentially. We'll use certain OTC products like Nix 1% cream, which you can get over the counter, or the Elamite cream. that can be used for scabies and refractory head lice. Sometimes you'll find other OTC products that will contain pyrethrins and also piperonal butoxide. Again, doing very similar things to what we see with the permethrins there. RID would be the example of that. So one of the problems you run into is that permethrins work for most of the cases of lice, but we're starting to find that they're becoming more resistant. And so if a patient has failed multiple rounds of pyrethrins, then that's when you need to move on to more stronger therapies. And so we have one thing called malathion, which is ovide. This is actually a very hardcore kind of pesticide that we don't use very frequently due to potential side effects, but it can be used occasionally here. It is flammable because it's in an isopropyl alcohol base, so be careful not to use it around open flames and whatnot. There's also another product called ivermectin or Splice, which we can potentially use for head lice only. This would be a prescription product. And then one of the interesting things you can use as a follow-up to one of these previous therapies we've discussed here is use an 8% formic acid solution. It doesn't actually kill the lice themselves, but it will help to loosen the bonds that holds a lot of the eggs or the nits to the hair, because this is often the reason why we have failure of therapy is that you can kill off the lice themselves, but if the patient still has a lot of nits in the hair, even if you use nit combs and things like that, they can still hang around and cause reinfestation. Additional things we can try includes this crotamycin or Urax. Again, would be good treatment for scabies. We don't know the full the mechanism here as a scabicide, but it also has some good antipruritic activity by inhibiting things like histamine and serotonin release. And this will be good for basically killing the scabies and also providing a lot of itch relief for the patient. For pubic lice, we use a product called Lindane, which is pretty good at killing off the bacteria or the lice, but unfortunately, it tends to be not so specific just for the bugs, but also will affect humans as well. So you can actually see if you have too much application of this or you cover too large a surface area, you can end up having absorption and can lead to CNS toxicity, which is most often seen as seizures. You can use it sometimes for head lice, but we don't like to use it quite so often just due to those the toxicity. And again, kids tend to have thinner skin, have more absorption anyway, so just be aware of that. But again, due to the dangers here of this drug, the FDA did add a black box warning regarding that neurotoxicity and risk for seizures. Again, for the most effective treatment, you need to also shave the hair as well. That will give less places for the lice to kind of hide out. So treating warts is typically they're caused by human papillomavirus, and so the most common thing they do at the primary care level is to use keratolytic agents, basically breaking down that abnormal keratin there. And so the most common thing we do is salicylic acid products, so basically similar to what we saw previously with the acne products, but again, we basically just put the salicylic acid directly on the wart, and cover it up so that way it's occluded, and usually you see improvement 1 to 2 weeks or so as it breaks down that tissue, and usually a resolution in 4 to 6 weeks or so. Also some other products like a duofilm or compound W, which kind of does a similar thing, and then certain plaster products that you can apply depending on how diffuse the warts happen to be spread. For anogenital warts, we can also use podophyllum-based products. So this includes both the podophyllum resin, which typically gets used more in the clinic setting, typically avoided for pregnant patients just due to there's some risk for some teratogenic effects. And then also this podophylox, which can be used for outpatient use. Basically, you would do it for twice a day for 3 days, then you would hold for 4 days, and you kind of repeat this. It can be toxic to normal healthy cells in addition to the wart-based cells, and so it is one thing to consider where we kind of give the cells a break, and you have that 4 days off essentially, and you can repeat that several times. Another product we use occasionally is called Aldera or imiquimod, and I'll show you this more in detail on the slide in just a second. This tends to be a little bit safer in pregnancy and more effective in men and women than podophyllum, so this tends to be used a little bit more frequently. Obviously, one of the big things you can do to help prevent warts due to HPV specifically is going to be by using Gardasil, which is a vaccine that helps to prevent cervical cancer and also a lot of genital warts. And this covers several different HPV strains. There's actually an updated one that even treats more strains than this. There's a 9-valent one that we use nowadays. We'll talk more about that in the immunization section. Again, this imiquimod or Aldera, it's actually an immunomodulator that helps to stimulate peripheral mononuclear cells to actually release interferon alpha and will stimulate those macrophages and will help to stimulate other cytokine production like TNF alpha, interleukins. And so you typically use it for external or perianal warts. Sometimes you can use it for certain cancers as well. And so basically you apply it 2 to 5 times per week, and then eventually will help to get rid of the warts over time. Basically, the biggest interaction you're going to see here is skin irritation. It's very irritating, so most patients are going to experience this, so good to educate about that. And basically, because it is stimulating the immune system, the more inflammation you see there, the more erosions, the ulcers, usually that means the more effective it's being. So if it's really being a problem for your patient, it probably means the drug's working pretty well. For patients who are experiencing atopic dermatitis, several products we can use here. Mostly it's going to be including things like corticosteroids and those topical immunomodulators we talked about previously. For patients who, just as a kind of a simple soap-free cleaner that you can use for these patients are very sensitive. There's a product called Cetaphil that can be useful for them. And then also if they're having kind of any kind of acute weeping lesions, this is where we can use things like aluminum subacetate, which is called Dombro tablets. It can be used as a drying agent. You can make a Dombro solution essentially from these tablets. It can be useful. And then also colloidal oatmeal, which is found in vino-based products, tend to be pretty soothing to these lesions. And then also if you're having like itching, things like that, which we'll talk more about these in the ENT section, but you can use a drug like hydroxyzine, which is an oral antihistamine that can be useful for a lot of that, some of that histamine-based itching and irritation. Just a few pictures of atopic dermatitis in some of your patients, how that might present. Some other random topical conditions we'll talk about. If you're having seborrheic dermatitis or dandruff, typically what we find is that shampoos that have some of the active ingredients, including things like selenium, which you'll find in things like Head and Shoulders. Ketoconazole is actually an antifungal drug, and tar can be very useful for that. If it's really severe, you may use topical steroids. That's going to be pretty rare. You may see that more if you're working specifically like a dermatology office or something like that. We'll talk about fungal infections in a different section, so we'll cover that a little bit later on. And then also herpes simplex, we'll cover that in a different section as well. So we'll cover those as we get to them. This is just a picture of what seborrheic dermatitis looks like. And then for psoriasis, again, you typically see this a lot like in the nails, the scalp, knees, and elbows. Typically what you're going to do is similar to some of the other dermatitis we saw there, where you're going to use a really high potency steroid up front, and then as you kind of get down and deal with that flare up, then you can use more kind of weaker steroids for more kind of maintenance therapy essentially, right? Sometimes occlusive dressings can help with this, to help with the irritation there, and then sometimes we'll use this calcipotriene ointment, which is actually a vitamin D analog that tends to have some positive effects on treating psoriasis. Don't want to use this on the face of the groin due to absorption issues. And it's incompatible with other steroids. So again, if patients have failed steroids, this might be another thing we can possibly use for this. We see our tazarotene here, which we saw used previously with for other retinoids that we can use topically. This will be compatible with steroids, so that's okay to use there. And then sometimes if you're having a lot of scalp issues there, using steroid solutions can be useful. For more generalized psoriasis, you have, say, greater than 30% BSA. This is where sometimes we use things like outpatient UVB light exposure 3 times weekly, or other immunosuppressives can be used for those patients. Just a picture of what psoriasis looks like, pretty severe cases. All right, so that covers the derm section. We will have our first assignment will be based on some of our dermatology stuff, and then we'll also have our first assignment, which will be due at the time of the first test. But if you have any questions in the meantime, please feel free to email me, and we'll talk about it in class. Thanks a lot, and I'll see you soon.